All right, so today's talk is the second in our early psychosis training series. We'll be focusing on early intervention in psychosis or early psychosis treatment approaches. It's a follow-up from last month's talk that was focused on early identification in psychosis. So today we'll be focusing on early intervention services. There's a lot of different names for it that I'm going to throw at you. Early intervention services, coordinated specialty care, step care. So I'll talk about all of them a bit interchangeably, but we'll discuss what is early intervention service or coordinated specialty care, why it's important, does it work? I'll overview the early intervention service care pathway, and then I'll share with you kind of all of the key elements of care, and we'll touch on each of them. So as a reminder for today's talk, it will be touching on each of the elements of care, and then subsequent in our series will go more in depth into each of those elements. And then lastly, I'll remind folks about the Step Learning Collaborative and share with you some new offerings that we have. Getting right into it. Last month, we talked about early psychosis basics, identifying the signs and symptoms of psychosis and kind of asking some of those basic questions in order to identify them. And so that was a bit of our early detection piece, which again focuses on kind of our mind map campaign. So again, kind of early detection is a separate component where we're focusing on shortening that delay to care or shortening the duration of untreated psychosis. And today we're going to talk about what actually happens. What do we actually do once we get folks into care? And so that's the bit that, for us at STEP, it happens in the STEP clinic, and that we hope will be eventually happening in different ways in clinics across the state. And so this will be the intensive treatment that occurs within the first 2 to 5 years after, or, right after onset of psychosis. So this is dubbed CSC, Coordinated Specialty Care, and it really focuses on reducing relapse, maximizing functioning and recovery. Initial interventions and ones that are still used for early psychosis treatment have been adapted from the more chronic serious mental illness population down to younger patients. And there's really kind of goal of phase-specific interventions, which we'll talk a little bit more about throughout the talk. Does early intervention for psychosis work? Yes, we talked about this last time. I emphasized it a ton. Psychosis is treatable. Treatment works. There have been multiple observational studies as well as large randomized controlled trials that show in this intensive treatment within the critical period, so that those first 5 years after onset of psychosis is just so important in order to help folks, and intervention during this time frame has disproportionate benefits compared to intervention later on, although certainly never too late for folks to engage in their recovery journey and experience benefits from treatment and supportive therapies. To talk just a little bit about those large randomized controlled trials, STEP was one of them. The STEP clinic was founded in 2006 and actually completed the first US randomized controlled trial of what was called at the time specialty team-based care, and that has since been termed CSC, or coordinated specialty care, which is now the kind of gold standard treatment for early psychosis intervention. And so STEP's model has been influential in the creation of first episode programs across the country. And as you know, we're working to grow the capacity of first episode services here in Connecticut, and are really excited about all of the LMHAs and clinical sites that we've been able to partner with through the STEP Learning Collaborative. And so benefits of CSC, you can see them there: reduce instances of relapse of psychotic symptoms, reduce readmission to hospitals, increase medication adherence, decrease in suicidal ideation and completed suicides. Of course, other important outcomes like social and vocational functioning, improvements in quality of life, and of course, when partnered with early detection, able to shorten DUP. I wanted to share with you the early intervention service care pathway. So STEP's care pathway has these 4 modules, which we think are important to care for individuals experiencing early psychosis. We already talked about early detection, right? So we consider that module A. That's the work that happens before someone even enters the clinic. That's the mind map campaign. That's the work that LMHAs are doing and engaging in across the state to try to kind of reach out into their community, let folks know, hey, these are the signs of psychosis. We're open for business. Kind of come here. Let's get folks connected. And there's specific strategies that we've talked about that are important in that, community education, detailing of specific referral sources, and then of course, kind of rapid access to care, trying to get folks, as soon as they're identified, get them in as quickly as you can. Try to minimize wait lists and enrolling folks into care to be able to kind of eliminate those delays that we know can be catastrophic. Module B for us at STEP is when folks do come into the door, and we kind of consider it the first 3 months of treatment. It's that initial evaluation and initiation into treatment. During this time period, we're really focused on trying to learn and understand the person as quickly as we can and develop our working formulation. You're, making sure you're managing risk, which of course you're doing throughout your work with any individual, engaging the family, starting initial phases of treatment. And then what we're going to talk about today, what I consider the real bulk of the treatment is what we call Module C at STEP, continuing treatment and coordinated specialty care. Right. As you can see here, we consider this a 2 to 3 year kind of dose of treatment, where I'll talk about all the main components of that shortly. But this is where you're doing therapy, you're supporting folks with meds, you're engaging their families, supporting their engagement and rehabilitation in the community, and connecting with various other things. And then lastly, for a specialty clinic like STEP that has a time limited duration of service, we consider care transition as an essential part of the care pathway, not one to just kind of be thought about at the last minute, but really being intentional with transitioning folks to the community clinics or different types of care, and helping support and make sure that they kind of stick there with whatever services that they need. So we're really going to focus on Module C today. Just some overall principles of care, which I imagine most places, engage with and adhere to, but we're always thinking about, we want care to be safe first and foremost, right? So we're focusing on suicide prevention, mitigating medication side effects, both short and long term. We want to provide effective and evidence-based care, both in terms of our prescribing practices as well as the psychotherapies and other interventions that are being provided to folks. Certainly being patient-centered, right? So offering folks choices, options, a menu of psychosocial services, which I'll outline shortly. It's important, especially working with this population of folks experiencing psychosis, that we anticipate variable levels of insight, and that we expect that will fluctuate throughout care, and that one works to kind of flexibly engage or re-engage folks into care, right? We're not just discharging them if they don't show up. There's kind of a bit of an assertive engagement nature while still respecting the individual's autonomy. It's important when working with psychosis to anticipate stigma that the individual might feel about their symptoms, that their family might be experiencing, beliefs that the family has about the mental health system or past negative experiences. And we want to be inclusive with important people in the individual's life. Certainly important to be timely. As I mentioned, rapid access to care, be flexible, community-based access if needed, being equitable. So at STEP, we're kind of, the initial trial and then our continued treatment, we're very lucky that we're able to be kind of blind to insurance status, that all comers in our catchment area receive care, regardless if they have public insurance, no insurance, or commercial insurance, regardless of immigration status or documentation. And we're excited that through the partnership with the STEP Learning Collaborative and connecting with all of the LMHAs, that the 13 LMHAs and the 18 clinical sites that make that up are also engaging with these principles and will be accepting folks of all insurance statuses in order to really wrap their arms around this population. And then it's really important, as we know, but to be optimistic and hopeful. I mentioned this during our last talk, but certainly being recovery oriented, recognizing that recovery is different for every individual, communicating that to the family, holding hope that recovery in psychosis is possible. It doesn't mean that someone's life's going to turn out a certain way, that there's really a lot of reason to believe that folks can improve in the domains that they care about. So now getting into those elements of care that I was talking about. This is that Module C piece that I was mentioning. As many people know, although I doubt the folks in this room share these beliefs, but we never know, that there have long been myths and former belief that medications, which are the first line treatment for early psychosis, are the only necessary treatment for individuals with psychosis, and that psychosocial interventions are not necessary or not able to be benefited from by folks experiencing psychosis. This, of course, is not accurate. There's so much research to show the various types of benefit that folks experiencing psychosis can yield from different types of interventions. And so a menu of psychosocial services are an essential offering to best practice treatment for early psychosis intervention. And so these are the kind of main components of coordinated specialty care. We've got psychotherapy, pharmacotherapy, and health promotion, which we'll talk about. That's kind of your med management and also working with kind of overall physical wellness of the individual. It's essential to provide support for employment and education, important like ongoing longitudinal evaluation, always kind of reassessing, reformulating, taking in new information, and kind of sharing that as appropriate with the individual and family, providing family support and education to some degree, and then coordination with community supports and engaging, existing community assets like peer supports and other types of supports, which we'll talk about. We view these as the main elements of care. Kind of throughout all of this, there's coordination between these elements. And I think it's important to consider that these things, not everyone's going to engage in every aspect of coordinated specialty care. Like we mentioned, kind of being person-centered, seeing, based on the individual's presentation, their preferences, their goals, and the phase of recovery that they're in. A brief word on phase of recovery. It's important to think about folks being in potentially 3 different phases. One, we might consider like an acute or more engagement phase, where maybe they're just coming into care, maybe they have a high level of symptoms, maybe some good amount of treatment ambivalence. And so you're just really working on safety and engagement. And then you kind of have more of a stabilization phase where you're starting to maybe maintain some symptomatic remission of symptoms. You're working to prevent relapse. And then recovery, right? Where you're kind of actively engaging with goals that are important to the person, vocational or education goals, self-management. And these categories aren't completely clean and mutually exclusive, right? Sometimes we expect that folks will kind of ebb and flow between them throughout treatment. And again, that's to be expected. And that's something that we communicate both to patients or, individuals and their families, that recovery isn't always, a straight, smooth trajectory, that we expect kind of ebbs and flows. So we're going to start with touching on a little bit about the family support and education element of care. So how can we empower families, and it's important for us to recognize like the importance of families. A lot of times working with this population, they're young adults who many of them do have some type of family member or other supportive person involved in their lives, although not all. And we view family support and education as an important part of early psychosis care, and it's recommended for all families and support people. Engaging in family support can have a variety of benefits. As I mentioned, those benefits that we see just engaging in CSC in general, but when families are involved, you see fewer symptoms, hospitalizations, greater overall improvements, and of course, decreased caregiver burden and stress. So there's a variety of ways to offer supportive and educational opportunities for families. You might offer, I think at minimum, you should offer some type of education about psychosis, the treatment, and recovery. So like factual information about what psychosis is and make sure that's available to folks. Other key aspects might be teaching skills around communication skills to kind of keep that emotional climate cool in the family, problem solving, and I think, of course, crisis management skills, empowering families to know, okay, what do I do if there's a return of symptoms or a situation that feels unsafe? How do I engage and help? And then, just as I mentioned, that's important to the individual, connecting the family to local and virtual resources, whether that's family support groups or different things that exist in the community, can certainly be very beneficial. So just another slide on families. We'll have a whole other series of talks for families and carers that I encourage you all to check out. But some quick tips on this, right? So engage a family right away, right when someone kind of comes into treatment. It's a really great time to try to connect with a family and kind of don't waste the opportunity where a family is really engaged potentially after a crisis or hospital. It's a time to really kind of help families get on board. And of course, they have so many other things likely going on in their lives, so many different stressors. So it's a good time to kind of connect with them and let them know that they're an essential part of the recovery team. Try to be responsive, offer practical help, whatever that might be, whether it's getting paperwork filled out or helping them understand something. Try to be as helpful as you can be. Strategies to reduce stress and manage difficult situations at home. As I mentioned, I think it's really important that one of your earliest conversations would be making sure that a family knows, okay, what to do if symptoms progress and safety concerns arise, and what safety concerns might actually look like, helping a family understand when something might be an emergency versus it might be able to be handled at an outpatient appointment. Mentioned teaching, providing education. Families are such key members, especially if they're living with the individual or have regular contact, helping them learn to be a key team member and kind of monitoring for symptoms or early warning signs. And hopefully, if the individual will allow, providing them a way to kind of communicate with the team and letting folks know that, if the family is aware that the young person's in treatment, the individual is the one who kind of, if they're an adult, can dictate how much a family member can be involved, but that a provider can always receive information, receive collateral concerns or reports from a family member should there be concerns, even if we can't share it back due to HIPAA constraints. And then just some general tips of helping the family support the young person's goals. I think every opportunity interacting with a family member or individual is an opportunity to try to reduce stigma and blame. Fortunately, there's been a long history of blaming parents and particularly mothers for the development of psychotic illnesses. And that's just not the case. Yes, environmental factors are important, but more so, we teach about interaction between genetics and environment and that it's no one's fault. Normalizing this experience, sharing with families that it's more common than you might think, they're not alone, again, connecting them to others. And lastly, continuing to hold hope for the family when they feel like maybe all of a sudden their whole world has been kind of turned upside down and this was completely unexpected or foreign to them. And, really being that voice that like you're part of the team, there's certainly hope for recovery and there's a lot of things we can do even if change doesn't happen overnight. So here's a quick look at some of the things that we offer at STEP. I don't think there's any one right way to do it, but as you can see, we try to start with everyone at least getting a family welcome packet, which offers that educational information and have it available on a website or in your office. We've at different points in time done orientation workshops or joining sessions, and then can also offer individual family support. Again, not everyone needs this intensity of services, but I think trying to have an openness if a family is really involved or an essential player in the young person's recovery, that it could be important to involve them in care, provided the young person allows it. This is a little just glimpse of our family information packet, key contact information for family. They can put a face to the names, tips for communication. So this is, if anyone's interested in this for their clinic or adapting it, it's available on our website to support folks with that resource. And so there'll be a lot more kind of offerings about family support. I'll try to be more concise with the other elements because I know we've got a lot to cover today and I always get excited talking about all of this. So next up, pharmacotherapy and health promotion. As I mentioned in this component, major focus on kind of medication management, but also wellness of the whole individual. And our next month's talk will be led by our medical director at STEP, Dr. Sarah Riley, and our clinical director, Shannon Imatovsky, and they'll go more into detail about the kind of fostering health and wellness. And then later on, Dr. Srihari will do a whole training series about prescribing and pharmacotherapy in early psychosis. So this is just a quick overview of knowledge, particularly for clinicians who maybe aren't as familiar with the prescribing practices, but antipsychotic medication is a first-line treatment for psychotic disorders. So it should be offered to an individual presenting with psychosis. And we know that continuing effective medication prevents relapse of symptoms of psychosis. It improves long-term outcomes. It's pretty simple. It's not the only important piece of recovery, but it is an important piece. And that's why a prescriber should be involved, particularly, early on in the initiation of care with an individual presenting for first episode psychosis, and then should be routinely involved throughout, even if the individual is refusing or not taking medication. I think having a prescriber regularly check in and making those offers and assessing it is an essential part of first episode care. And so just a word here on, considering long-acting injectables, they support adherence and convenience. Folks do better when they're on those. I'm not going to get into all of these, but these are here for your reference and a little bit of a preview of Dr. Srihari's talk in the future, but discussing kind of principles for prescribing in first episode psychosis. And here's a little glimpse at kind of a prescribing algorithm. Certainly we all take things case by case, but to kind of have a hierarchy kind of in mind about how to approach prescribing for individuals experiencing first episode psychosis is important. So all of this will be available on the website and we'll go much more in depth. So the next main element of care, coordination with community supports. Such an important piece, and it's really multifaceted. Coordination kind of with everyone. We, as a team, as a coordinated specialty care team, right? Coordination is in the name, so you can imagine how important it is. So frequent communication and coordination within the team is important. And that team, right, includes the clinical team, yes, but also, of course, the individual and any family members or carers that are involved. And so primary clinicians are essential reporters to prescribers, they're probably the ones that are going to have the most contact and relationship, letting the rest of the team know about symptoms, distress, adherence, and things that are reported that can also inform the prescriber's interactions and knowledge of the individual. Liaising with existing community supports, right? So our Team members are frequently involved with schools, attending or at least kind of giving some insights into IEP or PPT meetings, sometimes liaising with employers if the individual wants us to, or supporting letters and different things like that, connecting with PCPs, connecting with crisis services. If one of our folks, while they're in care or initially trying to engage in care, is headed to the ER or an inpatient unit, we want to, of course, deferring to those places as the primary treaters at that moment, but letting them know we're involved, providing background, supporting the person's stay, continuing to stay connected with the individual to support engagement while they might be inpatient to, increase the likelihood of them continuing to stay connected upon discharge. Certainly a CSC team member would, liaise and coordinate with jail diversion representatives. And then it's such an important piece of kind of connecting with peers and peer supports. So peers can be involved in a variety of different ways. Some models have peers embedded within teams, and others kind of utilize peers that are in external organizations, such as Advocacy Unlimited's Bridger program, NAMI's peer support groups, other, sometimes even national or international organizations such as Students with Psychosis or Students with Schizophrenia, all have kind of robust peer networks that we try to support our individuals in connecting with. And as so many folks know, working in the mental health system, that a lot of times there's practical needs in case management for our folks. And sometimes that's the most important thing, or the most important thing to the individual in that moment, to get their basic needs met or try to reach their goals. So I mean, all team members on a CSC team, and there's different structures. Some folks have case managers, but on our team, everyone's engaging in kind of supporting folks with practical case management, whether that's supporting them with their transportation needs, benefits, housing, food insecurity issues, access to technology, especially when using any type of kind of hybrid models of care. And then overall, we're really focused on trying to reintegrate folks with age-appropriate supports that are happening in the community, not just those that are tied to kind of institutions. And of course, there's so many great offerings that exist within, community mental health centers or LMHAs and things like that. But I think it's really important to think about, especially for this age group, of not just connecting my client to this resource because their primary identity is someone with schizophrenia, but they're a young person. I want to connect them to a health and wellness place that's kind of out in the community, that's serving all folks, and really focus on kind of reintegration whenever possible with existing community supports. And this is a very nice segue into other important community supports: support for education and employment. From what we've found at STEP and other CSC programs is that one of the most helpful elements of care with engagement is having a dedicated facet to support re-engagement and important role functioning. And so usually for a young adult, that's school or work. There's, as many folks know, specific models of this: individual placement or support and IPS. Just like peers, IPS services can be provided in the community, but can also be integrated within a first episode psychosis or CSC team. And I think a lot of times when folks are coming in, many folks are not really identifying with experiences of psychosis or a particular diagnosis, but they are willing to engage because they're saying, "Hey, Dr. Sykes, when I ask them what they want, I want to get back to work. I need to make some money, or I just really want to get off this medical leave and get back to school and get back to my friends, get back to my independence." And so trying to help support folks get connected right away. And if you can have a separate person on your team, or like I said, an outside agency that you're able to kind of connect them with, I think that's a really important, again, in terms of engagement, but just also actually supporting individuals' recovery in a variety of domains. Now, the kind of psychotherapy element of care, which again, I have a whole kind of dedicated talk on in a couple months. So we'll try to touch on some elements of this today. And if I have some extra time, I'll pull up some additional slides. Here, I'm going to, provide an overview of different therapeutic areas of focus and approaches. And at STEP, we flexibly implement a variety of evidence-based therapeutic approaches. We're not, prescribing one specific method, although we certainly, all have training in kind of CBT for psychosis. I think a variety of different evidence-based approaches are helpful, can work. It's a matter, again, of kind of preference and need and what the person's presenting with to, I think, what should be kind of implemented. I've outlined here 5 main areas that I think about in the psychotherapy domain. At STEP, we tend to implement these through individual psychotherapy, which I do think is important, but I'll share a little bit where I think groups can play a big role in some of these offerings as well. So first, we'll talk a bit about engagement and developing a shared understanding of experiences and goals. Here, again, this is not completely comprehensive, but I think major points to hit on in the kind of engagement domain is this idea of befriending, which I'll talk about, developing a shared understanding of what's going on. And so I'll walk you through one of my favorite analogies, the stress bucket analogy. And this is also a good place for, if possible, kind of values exploration and goal setting, really understanding the person, understanding what's important to them and how you can align with them to try to help them move forward in their life. We'll try to hit at least a little bit on each of these areas to give you a sense. So in this engagement area, some tips. I know folks in this room are probably, have lots of great clinical experience. But so we're thinking about we're working with young adults, with psychosis. It can be challenging. Dropping out of treatment is a common experience, with approximately 30% of people experiencing first episode psychosis ending treatment prematurely. And so it's really important to think about, how can I engage someone, right? We can't do any work if they're not engaged. We can't kind of provide the help. This is such a foundational element. And I think starting with some of those things I just talked about, orienting around shared goals and trying to prove yourself right away, giving support right away, whether that's something that's just, practical. Let me help you with a bus pass. Let me help you with this thing that just, it feels very important and pressing to you right now. Yes, of course, I care about your symptoms. I care about assessing for safety and all these other kind of goals I have in my head that I think are important. But what can I do to help this individual right away? And I think that getting back on track is helpful language, or staying on track. I'm not kind of going in saying vary my language based on the individual that's in front of me, but I'm not necessarily saying, oh, I'm here to treat your schizophrenia or make your psychotic symptoms go away. I have to first figure out how the person's understanding their experience. So if I know that they've had a disruption in their functioning in some way, try to orient around that and see if we can help. And then, getting relief from distressing symptoms. Maybe that's someone's having really bad anxiety. It might be related to experiences of psychosis. It might not. Maybe they're having a lot of difficulty sleeping and they just want some help sleeping. So maybe that's where coming in with some distress tolerance skills, or the prescriber coming in with some support, and maybe even, something that can support them in their sleep, and really, as we always want to do, listen, kind of put the person at the center of their treatment and see how we can help them right away and kind of get that early buy-in by treating some of the most distressing symptoms to the individual. It's important to be slow with most folks and have a gradual approach. So this is related to both the pace of the meetings, the safety of the topics. And so by that, I mean, everyone's going to be different, but you might not cover as much as you think. You might need to kind of go slow. Some folks might not do well with a 50-minute standard psychotherapy session, and you have to split it up and meet for 2 30-minute sessions, or whatever the individual can tolerate, and kind of use that kind of clinical judgment and see how they're responding to things. You start asking about symptoms. Do they really get closed off? Do you have to kind of back up and focus on safer topics? I think this next piece regarding engagement, I know there can be organizational constraints and things related to billing, but as much as possible, being able to be flexible with young adults with this population and trying to be responsive. We get lots of requests for shifting appointment times. And like I said, maybe having shorter sessions than longer sessions, or rescheduling. As much flexibility as we can offer can really support engagement and kind of keep someone engaged, instead of those kind of hard boundaries of, okay, 3 no-shows and you're out. To whatever extent possible, if folks can kind of find HIPAA compliant or, secure texting options, we have found that incredibly helpful at engaging young adults. Most of them don't want to answer our phone calls, or certainly not listen to voicemails if we try to leave those, but responding to text. And usually we use those for kind of engaging, hey, an appointment reminder, or if you have an automated system in your organization that can do that, that's helpful too. But just kind of checking in, like, hey, missed you today, like what's going on, in the most kind of non-judgmental way, or can we get you in tomorrow? I think with all interactions aiming to be normalizing and curious. Certainly we'll continue to talk about this more, but avoiding direct confrontation, that's something you really steer away from, I think, until you've got quite the rapport and maybe you're engaging in a specific CBT exercise. But really, we're not trying to debate reality with folks. The experiences that people experiencing psychosis are feeling feel so true to them. So just saying that that's not true or that's not happening, we know that that's not going to be very effective and will probably only kind of damage rapport. So a bit on that befriending approach that I was talking about. So this is actually like the name of a thing. It's a style, it's a therapeutic approach for engagement, and that can be utilized throughout a therapeutic relationship. As I mentioned, thinking about the safety of those of topics. So you might need to learn about what safe topics are for rapport building, learn about the person's interests. All of this would kind of go without saying. We all know how to kind of build relationships with people, but I think it's just particularly important when you're working with someone who might be actively experiencing paranoia or have been potentially socially withdrawn for the past year plus due to their symptoms or whatever might be going on. So a real focus on this should feel like this is an important part of the work. It's not just it's not something to be glossed over. So learning about the person's interest early on, talking with them, helping them feel a sense of mastery, like learning from them. I've learned so much about different video games and shows and things that I never knew about, and it helps create that sense of safety, comfort, and again, the sense of kind of mastery that the other person can kind of have something to offer. You can use this approach too, like highlighting strengths of the individual. If they've shared with you past positive memories or experiences, you can call on those, particularly in times of distress with an individual. Like, oh, hey, like, yeah, I remember when you told me about that vacation you took, or how you love taking your cat here, or giving your dog ice cream, or wow. And you can kind of call on those things that in moments of difficulty within the relationship. Or again, we often think of befriending used at the beginning of someone entering into care. But as I mentioned, right, as folks might inevitably cycle through different phases of recovery, maybe they have a relapse of symptoms or they disengage from treatment for a while and need to come back, pulling on this rapport and these strategies are important. And we've done, various things, which I'm sure are also utilized in a variety of young adult services programs and things like that. But participating in pleasurable activities together, playing cards in the office, or whether it's in a different location, listening to a song, having a cup of coffee. These are actual strategies to kind of help support kind of comfort. And as I mentioned, some folks won't require much of this at all. They want to get right into it. Other folks, you're in this kind of befriending engagement phase for a very long time. And sometimes that's where you sit. And of course, experiences of paranoia, hallucinations, or severe negative symptoms could impact someone's ability to engage with you. And you might need to utilize more or less of this strategy. I'm actually going to share with you one of my favorite exercises to do with clients. I like to do it with everyone I work with early on in treatment. It's a widely used analogy in the mental health field, so I imagine many of you might be familiar with it. I call it the stress bucket analogy. And the reason I like it is because you can use it with anyone, regardless of their level of insight into symptoms or labels, or their kind of language level. It's inherently normalizing. And so I'll walk you through it for folks who aren't familiar. Might start with a client kind of sharing with them, hey, so let me walk you through this analogy. It might be a little silly, but bear with me. It's something I like to use to kind of get to understand you better. And so you and I can, best support you and understand what's bringing you in here today. And so I'll share, I like to think that everyone has a bucket, and the size of the bucket is something that we can't control. We might just be born with a medium-sized bucket or a small bucket or a large bucket. And so we're thinking about how that's based on things like our family history, genetics, early childhood experiences dictate the size of our bucket. And so we've got this bucket, and it holds all of our stress, right? And so everyone experiences different types of stressors, but some common ones might be relationship stress, whether that be with partners, friends, parents, other folks. Life transitions, like transitioning to college, is a big stressor, or changing schools or ending a relationship. So you kind of have in mind, you highlight some ones that you might know apply for the individual when you're explaining it, but I also give, general ones. School and work can cause stress, experiences of loss. In my opinion, I think, sometimes drug use can add to our stress bucket, financial stress, experiences of discrimination. And so we've got this bucket, and we've got all this stress pouring in the top of it. And what happens when it starts to overflow? And this is different for everyone. What does it look like when your bucket overflows? So I might not use the word symptoms. It really depends, but this is kind of what I'm looking to identify when I'm walking through this exercise with someone. So here we're trying to understand, what does it look like for them? And so basically they're engaging in like a early warning sign relapse prevention plan right with you. So they might be able to say, oh, okay, yeah, this is what happens when my bucket overflows. And then you kind of share with them the good news is, yes, sometimes we can control what's pouring into our bucket, but sometimes we can't because stress is inevitable in our life. But we can poke holes in our bucket. And, some common things that are, good for poking holes might be learning different skills to relax or cope, engaging in therapy, medication, etc. Example of what this might look like could be maybe someone has an awareness that they have a family history of psychosis, or maybe they don't. So maybe we don't even touch on the kind of size of the bucket piece, but they're able to identify like, okay, yeah, no, I just all started a couple, months ago. I just started going off to college, and my parents, I just feel like so much pressure from them. And maybe they share that they use cannabis or something, but then they tell me, oh, Dr. Sykes, I don't think that goes in the stressor category. That's how I cope. And so we might agree to disagree there. I might share a little bit of like, okay, some coping strategies help in the moment, but don't help us long term. Might ask them, okay, so what is it when your bucket's overflowing? Like, what does it look like? Maybe they say, oh, that's maybe when I start to get some intense, scary thoughts. I don't know. I don't feel right. And so then I also ask them, okay, that's what's happening inside. If I was looking at you at this time, or like, how would I know? How would other people know that your bucket's overflowing? And they would say, oh, okay, well, that's maybe when I'm pacing around, or I'm kind of yelling at people or irritable. And then we kind of walk through, what are their ways to poke holes? And I actually usually start by giving an example of myself, again, inherently normalizing. This doesn't have to be about psychosis. I don't personally experience symptoms of psychosis, but I do feel anxiety and get anxious. And so I will, share with them, oh, when I'm stressed out with work or family or kids and all this stuff, or world events, I might share that like my heart starts like racing and I feel tension and I have a hard time sleeping. And people around me might notice that I'm much more snippy and irritable with them. I'm like yelling at my partner, and it's not good. And so that's a way, to whatever extent you feel comfortable self-disclosing or making up an example. I actually usually start with an example for myself and kind of share some of the things that I do. And so you can really, you can use this with the individual. I usually like actually draw it out with them. I give them a copy of it. We save it. We revisit it. Sometimes we pull the family into it as a way to just like normalize and explain. Sometimes we have the family fill out their own stress bucket, have the family, with the permission of the young person, I might say like, hey, if we're not getting anywhere, maybe I ask the family like, all right, well, what do you think? Like, what do you guys see when you think Johnny's bucket's overflowing, etc. So that's just one example. There'll be a lot more things that like skills like that and practical ways that we can talk through in some of the upcoming sessions and that are available on our website. But as I mentioned, that example was inherently normalizing. And that gets me to the fact of a key part of this kind of psychotherapy component is normalization in psychosis. We normalize experiences through a lot of ways, through psychoeducation, letting folks know that psychosis or hearing voices or however you want to say it to them is more common than they might think. 3 in every 100 people experience some symptoms like these, or you can share different types of stats and let people know. And they don't have to identify in a certain way, but kind of letting them know these experiences are common. You're not alone. Let people know that experiences of psychosis kind of impact any age, ethnicity, gender, SES, always instilling hope, discussing recovery trajectories, sharing, success stories of folks that are living with schizophrenia or psychosis, and having, working as doctors, lawyers, having families, artist, whatever it might be. Sharing those stories with folks is important because they might not be something that the individual or the family are aware of. Of course, a way to inherently normalize is connecting folks to others with lived experience. As we're mentioning, peers, online forums, support groups, advocacy organizations. It's important to kind of, you're normalizing, you're not dismissing. So if someone's coming in with a lot of distress, this is always a balance of, you want to say like, yes, you're not alone in this happens, but if you should check in with the person, because some folks, the normalization isn't going to land very well. It might feel like, no, Dr. Sykes, I don't care that you're saying all these other people are experiencing it. Do you get how bad this is for me, or like how difficult this is, or how much this is impacting my life? These are generally very helpful strategies, but just make sure you're checking in with kind of how it's landing with your client. Okay, so I've shared with you some of these stats and stuff. Like what does that feel like for you? What are you thinking? And if you get the feedback that like that's not a helpful strategy for them, then that's not really a direction to go for that individual person. Just want to share with you again, all of these will be available for reference and we can go more in depth into them in the future. But other, I think, key psychotherapy practices we're thinking about, we've got that engagement, developing shared understanding, now promoting skills. You can do this in so many different ways. And I think this is one that can be really kind of offered both individually, or sometimes this is a good thing to kind of offer in groups. But so I put a bunch of different acronyms here. As I mentioned, we don't prescribe to any particular evidence-based practice, but I think skills, CBT skills, dialectical behavior therapy skills, acceptance and commitment therapy, family-focused treatment, social skills training for schizophrenia, or social cognition and interaction training. Those are all some like key evidence-based practices that I think coordinated specialty care clinics can pull from to kind of help support and develop skills in young people and families impacted by psychosis. So we'll get into those a little bit more, right? Stress management skills. If I've been preaching about this stress bucket, that's certainly something I want to talk about, right? Like, as much as we can kind of help folks learn to manage their everyday stress with those basic things that we know are high hitting, like sleep hygiene, relaxation, exercise, harm reduction to substances. That's kind of a whole other element that's important to discuss within this, group or psychotherapy domain. Basic skills, structuring your day. I think we pull a lot, especially when folks are maybe in that more acute phase, with grounding strategies and distress tolerance skills from DBT. Really important to kind of have in someone's kind of coping toolkit, and to have kind of, even if they're in a more kind of recovery phase, you want to have them, as those holes that they can poke in their bucket, to know, like, what can I do? Should I start to experience some of these early warning signs, or should I start to feel that my bucket's overflowing? Again, you can use this normalizing language. It doesn't have to be your psychotic symptoms. It can be, look at when your bucket's overflowing, or when those intense thoughts start to come back, or those voices start to worsen. You're always kind of using the individual's, I think, language, and being guided by them, not withholding, factual psychoeducation about psychosis, but finding that middle ground. Certainly there's cognitive skills that we can teach, behavioral skills, and other skills, as mentioned, social skills, etc. Another key domain, which will be the focus of that talk in August, is changing the relationship to our internal experiences. So this is where we get to pull on cognitive behavioral for therapy for psychosis skills, cognitive restructuring, acceptance-based skills. This is where you're really working with experiences of psychosis or other distressing thoughts. And the goal of CBTP interventions would be, we're not just trying to get rid of symptoms, right? We're trying to decrease distress from symptoms and increase functioning and move in kind of meaningful value directions. So care is not just about symptom remission, although that's great and can often happen when effective care is delivered, but it's really about decreasing the distress that an individual experiences. We're not going to go over all of these today, but they'll be available for your reference, of different kind of phrases and ways to implement some CBTP strategies. And lastly, the ones, the kind of other areas that I like to think about, always thinking about kind of cultivating a life worth living, kind of pulling from Marshall Linehan there of DBT, but where you're exploring values, goals, really person-centered recovery topics. Therapy with an individual with psychosis can absolutely look like typical psychotherapy, or whatever that might be, but where you could be processing their episodes of psychosis, working with them on how they're integrating this new diagnosis or label into their identity, what it means for them, helping them promote autonomy. And then certainly, whether it's with the stress bucket or other strategies, always, I think, empowering folks to understand their early warning signs, as well as the family, so that you can kind of promote wellness planning and relapse prevention. So there's a bunch of other resources that'll all be available on the slide deck that you can click to if you want some more info on therapeutic approaches. And now I'm going to spend the last couple minutes just reminding folks what the STEP Learning Collaborative is and our current offerings. So that was an overview of all those elements. But for folks who weren't here for last week or at the launch, just a reminder that the STEP Learning Collaborative has been developed in collaboration with the STEP Clinic and program at Yale, with huge support from DMIS and DCF. And we've been able to kind of implement a statewide network of care for individuals experiencing first episode psychosis, building on the existing LMHA infrastructure. We now have launched the centralized referral line that anyone, any individual, family, care provider can call if they're concerned about an individual who might be experiencing first episode psychosis. And one of our early detection and assessment coordinators will connect with you, screen for psychosis. If the individual is eligible, we'll work to connect them to care as quickly as possible at one of these sites. An important thing to mention that I did not mention in last month's talk is that although our target age range is 16 to 35, some of the care providers and in some of these locations only serve individuals 18 and up. So in those instances, we'll be working with DCF affiliated outpatient providers for some of those 16 and 17-year-olds. There are some of the LMHAs that do serve folks across the lifespan. Feel free to kind of know about this number, share it widely with your networks. And some of the offerings that we have, you're here in the provider training series. We have our STEP consultation line, which is available for providers. I encourage you to address any questions that you have from this talk, send them to the consultation line. Folks like myself and other expert early psychosis clinicians at STEP and affiliates will respond to your question right away, whether it's a phone call or email response. This can be things about specific cases, individuals that you're working with. It can be about how to structure my outpatient program to better meet the needs of individuals with early psychosis, or just a simple question. Please use it. It's really easy to just put your name in, your contact info, and we'll get back to you right away. So here is the upcoming schedule for the provider training series. And we're excited to announce that we just put up a schedule for families and caregivers. I encourage providers to come because I think it would really benefit them in working with families. But thank you so much for attending. For more information, look at our STEP Learning Collaborative website or check out mindmapct.org.